Hello, I'm Amanda Steinman, Associate Editor of the Journal of Rheumatology. It is my pleasure to welcome you to this interview featuring the authors of an important article from the August 2025 edition of the Journal of Rheumatology. Today, I'll be speaking with Dr. Sebastian E. Sattui and John Stadler on behalf of all of the authors of our featured article titled Frailty and Associated Outcomes in Patients with Vasculitis. I want to thank you both for taking the time to speak with me today.
Thank you for the invitation, and it's, I think, on behalf of, John and all the co-authors as well for highlighting our work.
Wonderful. So we have some questions for you today, and we'll get started. The first question is, what motivated your team to examine frailty and vasculitis, and why do you feel this concept is particularly important in autoimmune rheumatic diseases?
Wonderful. I'll take the physician answer for to this question, which is at this point we know although this concept emerges in the geriatric and the geroscience literature and recognizes this syndrome that is associated to kind of a decrease in physiologic reserve that is associated to worse outcomes, initially described in older adults. Our concept and our knowledge of frailty has continued to evolve to better understand that this is by no means just a process associated to chronological aging, but also to a multitude of other factors. And what I usually kind of say that it's the not missing link between the connection of frailty and geriatric syndromes in our population is the role of chronic inflammation. So chronic inflammation has been recognized as an important factor that drives a lot of different kind of syndromes and aspects of aging, including the development of frailty. So that, besides the fact that the use of frailty is now being used in other specific medical fields to better understand outcomes and better kind of identify patients at risk for worse outcomes, inflammation makes also kind of the connection with our field in rheumatic diseases. We know from other conditions, and there's emerging literature with regards to rheumatoid arthritis, systemic lupus erythematosus, and now vasculitis, where we know that frailty has identified patients who are at risk for worse outcomes. And I think we're getting into a lot of our field where we're trying to expand and know that we need to improve outcomes in our patients beyond just the construct or the specific measures of the disease. And I think patients constantly remind us about this. So I think with the advances in treatments, we have the opportunity to expand our lens to better improve the outcomes of people who are living with chronic rheumatic diseases. And I think this novel lens allows us to assess vulnerability in a different way with the goal of actually developing a new target that allows us to better identify this. So our goal was this relevant. I've mentioned kind of all the points that it touches this. There's some data that has been done, particularly in patients with mild vessel vasculitis, but this study allowed us to better understand this throughout a broader spectrum of people who are living with different forms of vasculitis. So that's my physician answer to this, but I'll pass it on to John, who might have his view as well as a patient partner.
Thank you. As a patient who has vasculitis, it was very intriguing to me to understand what frailty was about, because in the early stages of my disease, I certainly experienced it. It was a long period of time which it existed and eventually got better. But it took me by surprise, and it was also something that was very difficult to live with, being 62 years old with the disease and suddenly having all the symptoms and issues. And I was pleased to be able to understand to a greater depth of what it meant to have frailty and how frailty affects the quality of life that we live.
Thank you so much for those complimentary and insightful answers, and it flows nicely into the next question. So this study leveraged the Vasculitis Patient-Powered Research Network. John, you have a unique perspective as a patient and a researcher. So what advice would you give to physicians who want to engage patients as partners in studies or quality improvement initiatives? And how has this experience changed your perspective as a patient?
I think it's really important that physicians take, especially rheumatologists, which is who mostly treated me, see a holistic picture, looking at both the disease and the disease state and how you feel as an individual, and addressing things like frailty and the ability to probably intercept some of that and to be able to provide additional support services. I think that frailty exists, and it's something that maybe you can do something with, or maybe not, but support services to help the patient through the experience to better understand it and to cope with it. This disease brings about many symptoms which are not necessarily clear to the patient nor understood well by the patient. And having this kind of information along with other pieces of information puts together the picture that allows you to take a holistic approach to how you're being treated and how you feel. And oftentimes, physicians will then engage you in a broader spectrum that improves fundamentally the quality of your life.
Truly a
Uh,
collaborative approach.
Mhm.
I'll add to that that also I think one of the things that we, that the part that to me is exciting about this study is the role of John and other patient partners from the BPPRN, since it's fairly inception to the very end of it in publication. And there's been, key insights as well, where the reason why our study within the VPPRN actually was called the VAST Strong study is because I think we all understand that frailty has a very negative connotation. And it may be a little bit unappealing for someone to participate and get this term of like I'm frail, where the idea is not necessarily noticing kind of on the frailty aspect, but also kind of figure out how we can develop interventions to improve this kind of innate strength, get our patients feeling better. And that spin-off, I would love to say that I have the mind to do that and come with nice names, but that was actually part of John and all the patient partners who actually help us develop this name for the study that actually ended up really transmitting what we want, which is allowing for our patients to get stronger, allowing for our patients to be, involved in their care. So I by no means can take, merit for that good name of the study.
Thank you so much. Now, your study uses the Frail scale to measure frailty. Can you please explain why you chose this tool in particular?
Yeah, so I'll start with briefly saying that, there's like a multitude of different tools that assess frailty in the geriatric literature, in the geroscience literature. As a matter of fact, nowadays we have specific tools for some other conditions in rheumatology that have been like specifically designed for specific diseases. Frailty is usually kind of conceived in like under two different main concepts. One of the phenotypic frailty that is kind of honed around the concept of the Fried frailty phenotype that actually sees this as more of a physiologic process and has measures of walking speed and exhaustion. And there's the other concept that's actually developed by Dr. Rockwood that actually measures frailty as a cumulative deficit process, where you start accruing different kinds of medical issues. So it's a list of medical problems that not only are diagnosis, but also like have to do with hospitalizations, use of medical equipment, and so forth. That and that's the other measure. So the Frail scale has a little bit of components of both, because it has some measures that actually kind of incorporate the components from the phenotype, but also has the illnesses component as well. But it's a very simple self-reported measure. It's quite short to be completed by a patient. It has been not validated in our patient in the vasculitis population. So of course, this is the first time it has been used, and that is something that we acknowledge to some degree the limitations of the implementation of this tool in patients living with vasculitis, but it has been validated against this kind of more stringent uses of initial definitions of frailty. The other thing that to us was appealing and also made this kind of implementation of the Frail scale feasible for data collection in the BPPRN is that, as we all want, a good tool that allows us to capture the data point that we want, but also to make that feasible. And we know that in a busy clinical rheumatology practice, having a dynamometer or having someone to sit through a list, we want something that can be actually implemented in care, that inform care in situ, to lead these discussions, as John was pointing out. And the Frail scale actually ends up offering that, because it's one of this a patient-reported tool that allows for easy data collection and capturing this. So it's something that also kind of motivated a little bit the use of this tool.
That pragmatism piece is so important. Now, I was struck by the finding that more than 60% of patients were classified as pre-frail or frail, and that age was not associated with frailty. So what are the key clinical takeaways from this finding for clinicians treating younger or middle-aged patients with vasculitis?
So I think this finding certainly kind of confirmed what our hypothesis was, in the sense that we felt that given what we know, kind of the impact of disease, living with a chronic disease, living with vasculitis, and although it comes in the path of the disease, that pre-frailty and frailty were going to be more common, independent of the fact that we were not necessarily only including patients within an older adult population. So it's important and we saw this, as you pointed out, throughout like most of the different subtypes of vasculitis, right? Because even though the majority of the patients included in VASTRONG are patients who live with GPA, we do include all different forms of different vasculitides of patients who reported. It's important to acknowledge that even though the proportion might be high, there's some subgroups of diseases where, we have a smaller group, so it's very difficult to fully extrapolate that for the whole spectrum of that specific form of vasculitis. With regards to the age component, again, I think we're talking that this is important, as I mentioned initially, although age and physiologic aging can be one of the risk factors we usually conceive this, and this is a concept that, again, was initially described in the geriatric population. This is by no means just a synonym of age, and that people who have been living with chronic conditions, who have risk factors like different comorbidities, medications, living with chronic inflammation, issues with mobility, independent of age, kind of can increase your risk of frailty. And this important part for the clinician is understanding that age is not frailty, and that there's a need and a value of screening this not only in population over the age of 65, and that this could potentially also kind of describe those patients who are, as John pointed out, explaining those other arrays of symptoms that go beyond what we usually conceive of the disease.
Absolutely. Thank you. Now and John, go ahead. Did you have further to comment? I didn't want to interrupt.
Well, that's a great question, and I think what's interesting, because you end up with this chronic disease, that frailty affects you at any age, and I think I was originally diagnosed when I was 62. I'm now 70, and I eventually became comfortable with it. But if someone is in their 30s or 20s and have the frailty, it probably takes them by surprise, and many of them are bewildered by all the things that are going on. As Dr. Sattui talked about, treatments and the inflammation, the disease effects itself along with frailty. And so having that understanding and having a multidisciplinary approach to the treatment regimen helps you actually feel comfortable with and work with the symptoms and acknowledging them. And it really does affect mental health and well-being and the ability to be mobile and live a productive quality life. As you can imagine, somebody in their early ages are trying to work as much as they are dealing with the disease itself. So they have a much more added a challenge along with family and stuff. So clarity and understanding creates awareness, and awareness creates the opportunity to do something about it.
And this really seems like it contributes to a holistic approach to patient care.
Mm-hmm.
And this leads to my next question, which was that you found that frailty strongly linked with poor patient-reported outcomes, especially pain interference, fatigue, and depression, as well as worse physical function. Now, how might this finding influence approaches to disease monitoring, to multidisciplinary care?
I think already, John started answering this question fantastically, which is exactly what looking into these constructs that allow us to better understand and holistically kind of approach patient care beyond the specific metrics of a disease, allow us to really impact the quality of life of our patients. Because these measures, again, not surprising, because this is what it's reported across the board through whether it's older adults, people living with other chronic diseases. We do see constantly these associations, and again, allows us to better understand outside of the specific treatments for the disease, and probably start thinking of how to borrow from other conditions, because we know that physical activity interventions, John already mentioned the mental health kind of aspect of this as well, nutrition, and all this other kind of, sometimes most of them non-pharmacologic interventions that we keep. Now we're now starting to talk that we're now starting to explore to better improve outcomes in our patients will be needed. We talk about multidisciplinary therapy very often in any of our diseases when you have the nephrologist and the pulmonary person, and I think we need to continue expanding what multidisciplinary approach is, which includes physical therapists, mental health, nutrition, because at the end of the day, these are all the aspects of the daily life that is impacted in our patients and where we need to continue to approach. And the importance of recognizing this and the importance of recognizing targetable aims such as frailty allows to better justify this and implement this in the care of our patients as well. Because we know that this has already shown, and there's studies in kind of older adults or patients living with frailty, for example, in cardiology, in the cardiology field or the oncology field, where these interventions have also shown to help with outcomes to ameliorate frailty. So it's, again, we don't need to reinvent the wheel, but start borrowing some of these concepts, some of these interventions, and adapting them to the best way and implementing them for our patients in the clinical practice.
Absolutely. And John, any further comments from your perspective?
I think Dr. Sattui did a great job, and I responded a little bit ahead of schedule in terms of the other items. But I do believe that the mental health and the stress that goes with the disease is challenging enough for people in the first 1 to 2 years. And it can't be understated how it affects them from a mental health standpoint and their ability to be socially engaged, whether being, constantly dealing with the disease and physicians and the treatments and things. And so adding one more element of clarity about frailty and acceptance about that, and that the likelihood that possibly you can move on past the state of frailty is very important. And I think them having that understanding is comforting and very helpful.
I'll add as well to, because if not, I think the neuroscientists would be a little bit appalled by the fact that chronic inflammation and addressing chronic inflammation, which is something that is of a lot of interest in the neuroscience field right now. Well, we do that directly, right? We treat our patients with immunosuppressive therapy for the disease, and it also allows us, and I think there's where a lot of the targeted therapies that we have nowadays spike some interest in a lot of this kind of aging-related processes to better understand how this goes only directed to the disease, or if we ameliorate further than that, because there's, of course, a growing interest with regards to targeting inflammation in cardiovascular disease, in kind of cognitive decline. So, of course, adequate control of the disease itself is as important. So early recognition, adequate treatment, disease in remission or treat to target in kind of as well as I will say also minimizing kind of other complications, which we all know how much time we try to minimize glucocorticoid toxicity, for example, as a common issue that our patients kind of experience.
Thank you so much. And my next question, I feel like you've answered much of it, but I want to come back to it. I'd be remiss if we didn't address it directly. So you found that frailty is associated with increased rates of hospitalization and flare. Given these findings, how might clinicians integrate frailty assessment into routine care? And have there been any early mitigating interventions that show promise that you'd like to incorporate, for instance, in your practice?
So again, this at the end of the day, what this allows us is to better understand and better identify people who are at risk for worse outcomes. I think primarily, although we have seen this for hospitalizations as well, fortunately, we didn't have that many severe infections occurring during our study, but this has been also very well described in other studies as well. This allows us to better understand who do we need to emphasize specific measures on. And despite what I've already mentioned, such as physical activity interventions, education, kind of mental health, nutrition, we also need to assess fall risk, for example, in our patients as well. So assessing those, and it's something as simple as asking someone if they've experienced any falls in clinic, and it's something that I do as part of my kind of assessment in clinic. If they feel steady, allows us to better understand who might benefit from physical therapy. we cannot emphasize enough the risk of, and this message, of course, we should go through all of our patients, but we know that infections occur more frequently in frail patients as well. So we need to make that time to have that extra conversations about risk mitigation strategies for infections, including vaccination, again, minimizing glucocorticoids as much as we can in some of our patients as well, since that is the main modifiable risk. So that is kind of extra to all the other measures that we have discussed. And again, most importantly is allowing also for disease, as important is to keep the disease under control and having that communication. So I think it keeps adding to the importance of the multidisciplinary approach, the holistic approach to addressing all these other aspects. And I think Frailty primarily allows you to capture all of that and better target, as much as we should. We need to do this in all of our patients, who would be at a higher risk and who do we have to emphasize kind of more of some of these measures.
Thank you so much, Dr. Sattui. That rings so true to clinicians, I think, globally. And it's interesting to think about frailty as a dynamic and possibly reversible construct. And John, I think you spoke to this a little bit earlier as well. So what are the research or clinical implications for future care models for vasculitis in view of this?
So I think the interesting thing, and this is something that, again, is being seen in some of, not only our study, but some other studies and it speaks to the point of what most clinicians would say is like, if I go through this criteria of frailty and I have a patient with active disease, right? Well, sure, they're going to meet all this, right? And there's this component of frailty that goes kind of through the physiological aspect of it that can be accelerated by inflammation, and this had happened secondary, probably in the context of active disease. And this is a conversation that we continue to have, and that's where the longitudinal measurements come into play to better kind of capture this, not just as a snapshot, because we don't do that for any of the disease measures. So we should not do that for something as frailty that to some degree is dynamic, and in some degree we can certainly intervene as well. So I think we need to learn a little bit more, because and this is where like further longitudinal studies will come into play for us to understand how much we can modify that, because as much as we saw some transitions in our study, we didn't necessarily identify a factor specifically that was kind of associated with this. So we need a little bit more information. But again, I think measuring this longitudinally, trying to see and then understand what factors are changing, what is changing in the life of our patients, what is impeding their physical activity, what is, what other changes are really impacting their quality of life, would allow us to better understand the factors that drive this outside of the concept of disease activity, which I think is what is natural to us as rheumatologists to address, to better see how we can ameliorate this. To what degree can we necessarily fully ameliorate it or prevent it? I think it's something that we need to understand better. But it gives us a little bit of hope, understanding that we can certainly maybe ameliorate it, maybe reverse it in some of our patients. And therefore probably pulls our ear in order for us to keep looking in that direction, where we need to keep studying this and find more interventions to this. So I think hopefully more to come, more for us to understand, but making a case for this to become something else that we assess with the same goal that all of our other assessments have, which is improving the life of our patients.
Thank you both so much for sharing so passionately, so clearly about the findings of your study of frailty in patients with vasculitis with us. And to our viewers and listeners, please read the article titled Frailty and Associated Outcomes in Patients with Vasculitis. It will be available on the journal's website at jroom.org and will be featured in the August print edition of the journal. So thank you for joining us. We look forward to having you with us next month for the September 2025 edition of the Journal of Rheumatology. Now share your comments in X at jroom or email at manuscripts@jroom.com. Thank you both again.
Thank you.
Thank you very much.